It's my pleasure to join you here all today, and there's quite a lot of detail in here, and I do want to leave some room for questions and comments, so we will scoot straight in. I'll add my acknowledgement today. I'm joining you from the lands of the Yagara and the Turrbal peoples in Meanjin, and I pay my respects to their elders past and present and extend that respect to the elders from the lands that you're all on this morning as well. As Jimmy said, I'm Rebecca Lang. I'm the CEO of QNADA, and today I'm here to talk to you about the Alcohol, Tobacco and Other Drugs National Minimum Data Set, which is the primary way that our federal government understands who is accessing alcohol and other drugs treatment and what sort of treatment they're accessing in any given year. We'll skip over some of these things because we've only got half an hour, so there's no time within the kind of envelope for brainstorming or activities, but that's okay. I don't think you're going to miss out on too much. So the scope of the Alcohol and Other Drugs Treatment Services National Minimum Data Set is specialist alcohol and other drug services delivered outside of hospital settings. And it also excludes people who are accessing opioid dependence treatment with no other treatment being offered. So if someone was getting ODT but also accessing counselling, their counselling would be counted as part of this data set, but not their opioid dependence treatment. The data set has existed since the early 2000s, so it actually has provided a pretty solid measure of activity in the treatment sector over the last couple of decades, which a lot of other specialist treatment sectors are not able to say. Why is it useful? Well, it's useful because then we can produce things like this. So the Australian Institute for Health and Welfare is the custodian of the data set. And so they produce these reports. You can go to their website each year and pick up a copy of the report. But they're able to show that, for instance, in this instance, that closed episodes of care for methamphetamine treatment increased substantially between 2007-8 and 2016-17. You can see there that the Northern Territory is the small maroon bar. Unfortunately, when you put us next to Victoria, there's just such a volume of services delivered in Victoria that everybody else looks tiny in comparison. But these are the kinds of data. This is really the only way that we are able to tell who is accessing treatment and what they're asking for help for, which then helps, obviously, us with lobbying government for more investment in our treatment services, and particularly for investment in workforce development, as we observe the changing patterns of drug use across the community. I've sort of covered that one. Great. So the process is it varies from state to state. In your territory, I think you are submitting directly into a portal provided by NT Health. So they would do this work behind the scenes to clean that data and provide it to the AIHW. In Queensland, for instance, we provide that service to our members. So they will submit their data set to us. We'll do the logic checking and the cleaning of it, negotiate any errors or problems that we find, and then submit it either to Queensland Health or to the AIHW. So as I said, the pharmacotherapy, there is a separate data set for people accessing opioid dependence treatment or pharmacotherapy. And there are some questions around some jurisdictions that include tobacco cessation as part of their sector. So the ACT is a good example of that. And so if people are accessing services just for something like nicotine replacement therapy for smoking cessation, they would not be counted in this data set. But if they're receiving nicotine replacement therapy while they're in resi rehab, then that would be something that we would be acknowledging and counting. Obviously, in collecting this data, it's important for you guys to just let your clients know that some of this data is for the national minimum data set. What you're actually providing to the AIHW is not identifiable data, so there's no names or addresses and those sorts of things in it, but there are some elements that from a ethical perspective, you should be letting clients know that the information they're providing to you, you're required to provide as part of this data set. So I'm sure you already all have processes in place for that and understand, that when you're collecting data from people that you need to be making sure that it's protected from access by unauthorized people, and that you have a process for managing where access is inappropriate. So the non-identifiable way that they track people through this data set is called the statistical linkage key. It's not a terribly exciting thing, but it just gathers elements of people's identifiable data. So a couple of letters from the first name, a couple of letters from the last name, date of birth, and then the sex, which then means that that person's journey through other types of treatment or accessing other types of social services like homelessness services can be triangulated for research purposes and for understanding patterns of service use. So we know a lot of people who access residential treatment services either live in precarious housing or overcrowded housing, or perhaps are more likely to choose residential treatment because the alternative for them is to be unhoused. And so there is benefit in triangulating some of these data sets so that we can see whether we're seeing the same people or different people. It's also the reason that I'm able to tell you that on average, an individual person accesses 1.8 episodes of care in any given year, and that usually would be explained by someone accessing withdrawal management and then going to resi rehab, or perhaps going to resi rehab and then moving into transitional housing or outpatient counselling services, for instance. So the basic unit of measure in the NMDS is a closed episode of care. Now, the thing that most services say when they first come across this data set is how little of their client's story they feel like they get to tell with this data set. It's not going to tell you how well someone did in treatment. It's not going to tell you that someone avoided prison by coming to treatment. It really is a very basic set of demographics and information about the type of service provided. So it really doesn't tell the whole story in its own right, and particularly if you're offering things like social and emotional wellbeing programs within your resi rehab. Those sorts of things are not particularly well captured by this data set. So there's just a moment of just quietly accepting that this is just a piece of that puzzle, and that narrative work that we all do to really tell the stories of the people who benefit from coming to treatment can't be replaced by a data set. So the episode of care are only those that are closed, and so there are some rules around that. So one of the reasons that you can close an episode of care is because treatment has been completed, or you've lost contact with someone, or they left without, against your advice. And for some clients, it's just that you lose touch with them. And for those people, if you haven't seen them for 90 days, you can close their treatment episode on the date that you last saw them. And so that means that for data collection purposes, while the collection period runs from the 1st of July to the 30th of June, so the same as the financial year, we don't collect the data until October, so that, if you haven't seen someone between the end of June and the end of September, you can go back and close their episode of care. So the other reason you might close an episode of care is because someone has changed their treatment type or their treatment setting. So as I was saying before, if someone moves from residential treatment into outpatient counselling, you'd close their residential treatment episode and open a new episode for counselling if it was in the same organisation. And the other reason you might do it is because someone has changed their principal drug of concern. So someone might present to you saying their principal drug of concern is methamphetamine, and they might decide somewhere down the track that actually the strategies you've been giving them for working on their methamphetamine use haven't been working quite so well on their alcohol use, in which case you might close their episode. That one doesn't happen very often. Most often people present and they'll tell you all of the different drugs they're using, and it'll be a bit of a arbitrary sort of assessment process that decides which one of those is their primary concern. Obviously, we should be led by clients with that in that regard. So the other thing to remember is that you can have, if you're if two people, if you're delivering two different types of service, so say counselling services and case management services, you might have parallel episodes of care. So those episodes of care is kind of the unit of measure that this is built around, and it doesn't necessarily, so it's not necessarily client-centred, which is something I know that we're all very interested in. So one of the units of measure is that reason for cessation. So there are a range of options that you can select for this, and we've talked through some of those. So it might be that they've completed the treatment that was available to them. They may have, that might not necessarily be that they've done 12 weeks in a program. You know, sometimes we know people access treatment more than once, and so sometimes they will be looking for a shorter duration of treatment because they've got some recovery capital, and they may be just looking for a month, or after a month or 6 weeks, they say, I feel like I've gotten what I need from the program. That could still be treatment completed if you agree with the person and they exit for a planned reason. Those are the, you can be a bit creative with those. It doesn't have to be like our program is 12 weeks. If you don't do 12 weeks, then we say that you didn't complete the treatment. But there are a range of other, so, you know, if someone is breached and sent to their parole is revoked, and they're returned to prison. So there are a number of options that you can select in there. Yeah, not all of them are fabulous reasons, but, you know, it's good to know what happens to people when they're in treatment and why they stopped. So the client information that is collected is with the really basic demographics of a person's existence. So just in the last 12 months, we've added gender as well as sex. So obviously sex is that male, female, undetermined, or didn't prefer not to say, whereas gender is male, female, non-binary. So that data, that gender was a voluntary item in the last year. From this year, it will become a mandatory item. And down the track, I think we're headed for also collecting, also going to be collecting data about sexuality. You know, it's important because we know that LGBTIQA communities in our prevalence studies use substances at higher rates than the general population, particularly some illicit drugs. But we don't have any visibility about whether that translates into more LGBTIQA folks accessing treatment services. So date of birth is pretty straightforward. Sometimes, except for where people are not, may not have access to a birth certificate and may not have celebrated a birthday, so won't have necessarily a, they might be able to identify how old they, how many years that old they are, but without being able to give you a day and a month or a year that they were born. And so that's where these date accuracy indicators come into play. So they will say whether we so if you're unsure, you know, the year that someone was born, but not the month or the day, you would enter them in as the 1st of January for that year. But then in your date accuracy indicators, you would say that you were unaware of the actual day or month, but you're confident about the year. There's some coding that sits around that. Country of birth is, there's a whole, you know, most of the people who are accessing AOD services are born in Australia, and I think the most common countries other than Australia are still countries where English is the official language. So New Zealand and the UK. It is a ongoing kind of issue that we don't see a lot of culturally and linguistically diverse peoples in AOD treatment. We do see quite a lot of Aboriginal and Torres Strait Islander peoples, though. It's about 14% of the national proportion of the people accessing treatment services nationally identify as Aboriginal and or Torres Strait Islander. So we use the best practice standard for that, which is, you know, do you identify as Aboriginal, Torres Strait Islander, both, or neither? And there's a threshold at which the AIHW will get back in touch, because a lot of people would just say not stated. And we're hoping to avoid those not stated or unknown answers as much as possible. Often it's a bit of an indicator about staff's comfort in asking that question if you're getting a lot of not stated or prefer not to say responses in your data set, which might mean that there's an opportunity to do some work with your team to build their confidence around asking certain questions. In alignment with what I was saying earlier about country of birth, preferred language almost always is English. I don't think this one collects traditional Aboriginal and Torres Strait Islander language groups particularly well. It tends to go with that ABS. So it imagines language as we all speak English here in Australia and everywhere else in other countries is the languages that we're looking at. Again, this is another one of those ways where perhaps the data set doesn't tell the full story of the experiences of people accessing our services. So technically speaking, we can provide services to a person for either their own substance use concerns or for someone else's. Usually that would be a loved one. So think maybe family drug support. So they collect this data set, but their client group is focused on the family and friends of people who use drugs and providing them with support to I guess be a protective relationship for the person who is using drugs, who may not want to go to treatment, is perfectly happy with their substance use. So most of the clients coming through the system, I think it sits at like 98% or something, are there for their own use. And there's a whole bunch of things if it's for someone else that you don't fill out, but that's probably not important to dwell on. Source of referral, most of our referrals into the system are self-referrals, but there are a range of other options you can select for this one: health service, courts, police diversion, all of those sorts of things. It is, I think, I use this one quite a lot in advocacy to point out that we don't need to force people into treatment services. Where people know they exist, they will self-select when they feel ready for it. And we know that that's a more likely scenario to end with someone achieving their treatment goals. Not to say that the courts don't love to refer people to us. So the treatment setting is the main physical setting. So that's residential, non-residential, or maybe outreach. Main treatment is, so if you're providing residential treatment, there's an assumption that case management and counselling are part of a residential treatment episode. But if you're providing counselling and someone's also accessing case management, as previously said, that would be two separate episodes. So this a change in the main treatment provided or the treatment setting would be a reason to close an episode and open a new episode. But you can have other types of treatment. So for instance, if you were providing counselling to someone and you also were their opioid dependence treatment provider, you might capture that they were also getting pharmacotherapy. If you were doing counselling with someone, you might also do withdrawal management support for them. So there's a range of other treatment types you can select, but so long as you've got the main one in, you're golden. Principal drug of concern, we talked a little bit about this one. I think the current stats kind of say that we're sitting at alcohol and methamphetamine being fairly equal nationally at about 35% of episodes each. And then sitting behind that is cannabis, and then dwindling very quickly down to other drugs of concern like heroin or psychedelics or MDMA, which are really very low rates of use across almost everyone's in our treatment system is there for alcohol, methamphetamine and or cannabis. The method of use, so if someone tells you that their principal drug of concern is methamphetamine, then you might record their method of use as smoking or inhaling, injecting or orally, so swallowing. If someone's using cannabis, most often they'll be smoking that, although I guess they might also be vaping that. So it just gives us a bit of a sense of how people are using their drugs. Obviously, if they're using alcohol, they're likely to be drinking it. Injecting drug use status, we find a lot of clients in our system are not, well, except for the people using meth, up to that point, very few of our clients had engaged in injecting drug use behaviours. But it is good to know. This is another one that people can feel a bit uncomfortable asking, particularly if someone presents wanting help for alcohol, because it seems like quite a departure. So we do get a bit of not stated around this one, but it is best practice to ask this of everybody who comes into the service. A couple of bits on social information, so the postcode of the client, with a special code there if the person had no fixed address, and then again with not stated, but it just gives us, excuse me, we've had a bit of a conversation about how people move around. And so people might, especially if they're accessing residential treatment, choose to go to a different place to access residential treatment as a bit of a reset on their relationships. What sort of accommodation someone lives in. So is it a rental? Is it a boarding house? All of those sorts of things. And then the suburb. So this is just, again, to get a bit of a sense of how treatment sex services are kind of spread across the country and how people move through the system. A couple of case studies there, that's all right. But I know we've got one question has come up. I might just press on because we're almost at the end, and then we can have some dedicated questions. As I've said to you, we really prefer if you can avoid using the not stated or other, because those don't tell us very much at all about the people accessing services. And thinking about principal drugs of concern, it's really the drug that the person presenting is telling you is their most significant drug of concern. Some clinicians have the view that if alcohol is involved at all, it will be the most difficult one to give up because pubs are everywhere. I have a lot of empathy for that as a thought process, but if someone's saying that they see their issue as methamphetamine, we should be recording what they're saying is their issue. And I think that is the end of our